Hey everybody, and welcome to another lecture from CyberMD. Today we'll be covering EKG basics with a particular focus on the lead views and how they apply to EKGs for the USMLE Step 1 exam, as well as for clinical practice. Let's dive right in. On the slide, you can see a standard 12-lead EKG tracing. You will notice that the 12 leads are labeled Leads 1, Lead 2, Lead 3, AVR, AVL, AVF, and V1, 2, 3, 4, 5, and 6. Leads 1, 2, and 3 are all considered the limb leads. The leads AVR, AVL, and AVF are all considered the augmented leads. And finally, leads V1 through V6 are all considered the precordial leads. At the bottom of the EKG, you will notice that the leads 2 as well as the lead 1 is displayed again. However, this time they're displayed for a much longer period of time. These strips at the bottom of the EKG are known as the rhythm strip or rhythm strips. They can be useful if you want to look at a particular lead or a view of the heart over a longer period of time. One of the key takeaways from this lecture is that each EKG lead gives you a representation of the electrical activity of the heart from a different viewpoint. Let me show you what I mean now. Here, you can see an image of the heart in 3 dimensions, where each line is labeled with the lead that is associated with that viewpoint. The black lines are in the horizontal plane, while the yellow lines are in the vertical plane. Each of these leads is looking at the heart from a different perspective. You can see that lead AVR is essentially looking at the heart from the right shoulder area. You can see that lead AVL is essentially looking at the heart from the left shoulder area. Lead 1 looks at the heart from the left lateral side of the thoracic cavity, while leads 2, 3, and AVF all look at the heart from the feet. Those 3 leads, leads 2, 3, and AVF, look at the inferior posterior portion of the heart more than anything else. Leads V1, V2, V3, and V4 look at the anterior and septal portions of the heart, while leads V5 and V6 look at the apical portion of the heart. This is important because different anatomical structures and coronary vasculature are present in different areas of the heart. Knowing what part of the heart each lead predominantly looks at can be helpful in identifying likely origins of some pathologies, such as an acute myocardial infarction. Additionally, each one of these leads is considered a positive lead from the viewpoint that I've displayed on the slide at this time. This is important as the direction in which depolarization or repolarization occurs with regards to the viewpoint that a specific lead has will determine whether or not there is a positive or negative deflection on the EKG tracing. I'll say that again. The direction in which depolarization or repolarization occurs with regards to the viewpoint that a specific EKG lead has will determine whether or not there is a positive or negative deflection on the EKG tracing. Let's talk about this a little bit more. Before discussing the rules for deflections, I want to remind you that the general path of depolarization for the electrical activity of the heart is that it starts in the right atrium and travels downward towards the left ventricle. If you had a square divided into 4 sections that represented the heart, the wave of depolarization would start in the top left and travel towards the bottom right, where the top left actually represents the patient's right atrium and the bottom right of the square actually represents the patient's left ventricle. The rules for deflections are as follows. Rule number 1, depolarization that is occurring towards the electrode, towards a positive electrode, results in a positive deflection. Rule number 2, depolarization away from a positive electrode creates a negative deflection. Rule number 3, repolarization towards the positive electrode, again, repolarization towards the positive electrode creates a negative deflection. And rule number 4, repolarization away from a positive electrode creates a positive deflection. And finally, rule number 5, depolarization or repolarization perpendicular to the viewpoint of a positive electrode results in no net deflection. Let's now talk about how some of these rules create implications for EKG tracings. Because all of the depolarization happening occurs in the opposite direction from which AVR looks at the heart, and because repolarization of the ventricles occurs towards lead AVR, all of the deflections in lead AVR will be negative. Additionally, you will find that the QRS is mostly negative in V1 and V2, while it becomes isoelectric in V3 and V4, meaning no net deflection, and then finally becomes mostly positive in leads V5 and V6. Finally, you will note that there are only very small deflections in lead AVL due to the perpendicular nature of its viewpoint compared to the path that the depolarization takes throughout the heart. Now that we have established the foundation of how different leads look at the heart from different perspectives, and how the depolarization and repolarization of the heart can affect whether or not the EKG tracing is positive or negative, let's look at how the individual lead views become relevant not only for the USMLE Step 1 exam, but also for clinical practice. You will notice that both of the tables on this slide are arranged in the same way that a 12-lead EKG is arranged. On the top, you can see that the leads 1 and AVL are considered the lateral leads, meaning that they look at the heart from the patient's left lateral side. Leads 2, 3, and AVF are considered the inferior leads, as they look at the inferior and somewhat the posterior portion of the heart. As previously stated, V1 and V2 look at the septum of the heart, while V3 and V4 look at the anterior portion of the heart, leaving V5 and V6 to look at the apical portion of the heart. The most important part of all of this, however, is that each area of the heart, such as lateral, inferior, septal, anterior, and apical, are all associated with various coronary arteries as well as their derivatives. You will notice that the lateral leads are associated with the left anterior descending and left circumflex arteries. This means that EKG changes in these leads may signify pathology in those vessels. This is especially with regards to myocardial ischemia and infarctions. Leads 2, 3, and AVF may all look at right coronary artery, left circumflex artery, and posterior descending artery pathology, depending upon if they have right or left dominant circulation with regards to the posterior descending artery. For more information on that, watch the cardiac anatomy lecture. Leads V1 through V4 all look at the areas of the heart that are predominantly supplied by the left anterior descending artery. Because the left anterior descending artery is the most common site of myocardial infarction, these leads will often display ischemic changes during a myocardial infarction. Finally, leads V5 and V6 may look at the left anterior descending artery or its derivatives, or the left circumflex artery and its derivatives. This is because they look apically, and the apex of the heart may be supplied by either of those two arteries. You will note that the lead AVR does not look at a specific coronary vessel, and it is often thought of as the forgotten EKG lead. But you can see some changes on this lead that are considered reciprocal changes whenever you have pathology in leads AVL, 1, V5, and V6. Now that we have discussed this, let's take a look at a diagram that shows it. You can see here that lead AVL and lead 1 will encounter the left lateral portion of the heart first from their vantage point. This is associated with the left circumflex artery and its derivatives, which are labeled. You should be able to appreciate how the viewpoint from leads V5 and V6 may allow someone to look at portions of the heart supplied by either the left anterior descending artery or the left circumflex artery, while leads V1, V2, V3, and V4 will all look specifically at areas supplied predominantly by the left anterior descending artery. Lastly, you can see how leads 2, 3, and AVF will all look at the inferior and posterior portions of the heart, which are most likely supplied by the right coronary artery and its most likely derivative, the posterior descending artery. But if you know about left dominant circulation, this could also be an area associated with the left circumflex artery. In conclusion, each EKG lead looks at the electrical activity of the heart from a very specific viewpoint. The viewpoint of the electrical activity that each EKG lead has will determine the morphology of that lead's EKG tracing deflections from baseline, depending upon the direction of depolarization or repolarization with regards to that lead's EKG viewpoint. Additionally, because each lead has a specific viewpoint of the heart, each lead looks at areas of the heart that are supplied by various major coronary vasculature. The knowledge of which EKG lead looks at an area supplied by a specific major coronary vessel can help a clinician in localizing the most likely site of pathology with specific regards to myocardial ischemia and infarction. Thanks for tuning in, and be sure to like, comment, and subscribe to our content so that we can continue to provide free medical education resources to medical students around the globe.